Hey folks, Scott Weingart here, and this is the One-to-One Nursing Podcast. This is a podcast on resuscitative nursing and critical care nursing. I will shortly be joined by my co-host, Candace King, and let's roll right into the episode. All right, Candace, welcome back to One-to-One Nursing, our resus nursing podcast. How are you?
I'm lovely. How are you?
I am wonderful, though I can't wait for the summer to end. Can't come too soon when fall comes around. I'll be a very
Is that
happy
because
man.
you're allergic to the sun?
I don't like the sun. I don't like the heat. I don't like the humidity, especially. And I'm a winter boy. So we will just hibernate until that is the reverse bear is what I am.
I think you could spend a little bit of time in that beautiful backyard of yours. That's the purpose of having that.
I don't know how much people actually care about this. In New York, Eastern Long Island, where we both are, the mosquitoes ruin everything. They just ruin everything.
Yeah. They do. But still, you could at least go out there in the evening time.
I do.
When
I do.
You won't melt like a vampire from the
as you
sun.
imagine, when it's nighttime and no one is around and the stars and moon are out, that is when I am outside on my deck.
No surprise here to hear you say that. Meanwhile, I go outside and attempt to burn this skin of mine, and I come back in just as pale as I did outside.
Oh my. But enough about us. Let us get to the topics at hand. So we are doing our first follow-up and question and answer show. And the people who care, and there are a lot of them out there, about Candace's well-being in terms of foreknowledge about the show, will be happy to know that for Q&A shows, I do send her everything we're talking about ahead of time. I would not stick her into this cold. So she does know what we're speaking about.
Yeah, I do. You sent it to me last night. He gives me, really, guys, a lot of preview time, probably because of my type A personality, and he knows I'd obsess over it. He'll give me 10 hours worth of prep time.
Yeah, more than enough. All right, let's do follow-up first. We got a response from Kane, last name withheld. Why are you two both talking about rectal temps? Why not just use tympanic? Do you folks not have these in the States like we do in Australia? And I'll let you go first, Candace, and then I'll give my 2 cents on that.
We used tympanic temperatures during COVID, right? And I think that showed us that we didn't do a great job with them at all. And they were grossly different than rectal temperatures. And certainly it's technique driven. And if your technique isn't spot on, I felt every time I did the temperature, it was different. And that to me is, where's the reliability in that? So yes, they are available. Do we use them for critically ill patients? I would say a strong no. I would say for a pediatric patient that's not critically ill, has a runny nose, certainly I wouldn't aggravate them in doing other things. But when you're making decisions on how to treat critically ill people or whether they're borderline for sepsis or you're looking for an infectious process, I just don't find them as reliable. And I don't actually stock them at all in my critical care space. I only stock them in peds triage, and that's to not aggravate a child. But otherwise, I probably wouldn't use them really at all.
Yeah, I couldn't have said it any better myself. And the literature supports it. Yes, tympanic probably is a little better than oral, but it doesn't matter that it's better because it's not good enough. And what you need is good enough. You need something truly accurate, and it will miss fevers. It will miss hypothermia. And we put some of the literature in the show notes for this, but it's just not good enough is what it comes down to. So I don't care if you screen with oral or tympanic for ones where the temperature doesn't matter. You're just filling out a vital sign. But if you care, then you probably need a rectal temp. All right, next one up. And a few people mentioned this. I don't know if we have to say anything about this because neither of us use Epic, but a bunch of people wrote in and said on Epic, there is a feature that allows the nurse code leader to actually write everything that happens on the code, and then the doc could just sign off on that all at once. They call it the code recorder function, and it sounds great. We don't have it, but if you do, then look into that. Anything to say about that, Candace?
We do that on paper.
Yeah.
So same concept. We just use a paper, scanning it as a PDF. I think it's the same process, just not an option for us in our electronic health record.
Gotta say, I prefer the paper.
Great that people have it.
Yeah. Even if I had it, I'd still prefer the paper. The paper just works beautifully. As long as the docs afterwards put in what was done just for recording purposes so the people upstairs could see what the patient got for their intubation or what have you. But paper is just so much easier. It means the podium nurse, the nurse code leader doesn't have to be using a computer because that takes their 360-degree awareness away. I just like paper for this a lot. All right. This one, Candace, listeners wrote in. I have this question too. I think it was our first episode, we talked about drawing from existing IVs, and you said that they should use the actual vacutainer transfer device to the IV catheter, and it wasn't quite clear whether you were against syringes or you just were saying that's easier to do than syringes, and people want a clarification on that.
Okay. I don't use a syringe because I'm concerned about me, right? And my fingertips. And I've been stuck by a high risk patient before. And then you have to ask that question of what meds are you going to take or not take. So if you put the vacuum container directly onto your clave or whatever you have at the end of your line, it decreases the provider's likelihood of getting a contaminated needle stick because you're putting your blood tubes directly into the vacuum container and the needle is not exposed to the person. Can you use syringes? Sure. Do I use them when I'm drawing off an arterial line? Yes, because I have no other option. And then I use a safe transfer device. Now, remember, I call myself a seasoned nurse. Nice way of me saying maybe I'm not in my younger 20s. I didn't have transfer devices when I first started, and that's how I got stuck, just to share my life experience. And I don't want to do that again. Now I have a son, and I think about my wellness and how to protect myself and my family. And this offers me a safer mechanism. And that is the only reason why I don't use syringes. I want you all to be equally as safe when you're practicing. But if you have to use syringes, certainly you can. You can't let them sit around in the syringe too long, right? Because then it causes its own hemolysis, which you don't want. And some of the tubes are heparinized, right? So you get the blood directly into the heparin and not into another syringe. And then the other thing on top of your safety is you have a lot of touch points, right? So I'm touching the IV with the syringe. I'm touching the syringe with a transfer device. I'm touching the top of the tube. And human error is reality. And I think that if you can reduce your touch points and be safer, that's the best practice.
Yeah, that all now makes complete sense. So a few things about that. I'm curious, Candace, you said you can't just use a vacutainer device into an art line. Why not? You just go to the three-way stopcock and attach there, waste the tube, and then draw from there. Why do you need syringes?
I guess you can, but usually the pressure that kind of is built into the art line, it will shoot the vacuum container out. When you attach it to the clave, it holds it. It's got like a little snug hug on it. And on the arterial line, it doesn't have that. That I think is the difference. You certainly can do it, but you're holding it gripped. I tend to use syringes for that so that I know that it's on correctly and I'm not going to have waste into the bed or anything else.
All right, that makes sense. I do use the vacutainer devices on my art lines, but I do have to hold them just as you say to prevent them from falling off.
Yeah, it doesn't give the snug hug, which I think is what I'm looking for. I'm a person with small hands. I don't have the same kind of dexterity as somebody like you who have longer fingers.
Fair. Now understand where you're coming from. If anyone is taking a syringe and attaching a needle to them and putting those into tubes, that is insane. Don't ever do that. That is really dangerous because it takes a lot of force to get through the tops of those blood tubes, and you will eventually cut yourself. So I couldn't agree more with Candace. Now, Candace, my place does have the safe transfer devices. I think if you use those, very safe. If you don't, what I recommend is actually popping the tops off of your blood tubes. And then you could just have a needleless transfer. And that is okay. They've studied that. It is acceptable. But you're right. It's a lot more complexity. It's a lot more capability of screwing up. You now lose the built-in taking the right amount of blood into the tube that the tubes have built in. So you might overfill, you might underfill. So best choice, yes, attach a vacutainer device to whatever you're drawing from, the IV hub or the clave hub. But if you have to use a syringe, and sometimes we do, I'll do a femoral stick just to get blood rapidly and hand the nurses a syringe. Don't use a needle for that transfer. That is crazy. All right, that takes us through follow-up. Let's get to questions. There are a few questions out there about they want a general setup of the Janus General ED-ICU, was the RAC. Now I believe it's the REC, the Resus and Emergency Critical Care Unit. I've put up a picture there of its idealized form with the proper room numbering. I don't know if that room numbering's ever happened, or was still misnumbering, but regardless, you now have blueprints of it. That'll give the basic idea. So there are, in essence, 22 bed slots when things are going well. Those will expand to 25 quite easily. 3 beds that should be single will go double. And then there are hallway beds. How many designated hallway spots do you have there, Candace?
4. And
With
they're monitored
monitors,
hallway beds on a central station. 4.
All right. So now
and have this beautiful curtain for lack of privacy.
So now we're talking about 29 monitored beds. If it swells beyond that, then things are really bad. But already, that's an enormous unit. How many nurses are staffing that anywhere from 22 to 29 beds, Candace, on a good day?
7 staff nurses, 1 lead is meant for something about over 24.
Yeah.
Pretty consistently, I start at 5 nurses in the morning, and the census will be 6 or so. And then I add a nurse at 11 o'clock to make it 6, and I'll add a lead. And sometimes the lead nurse will just let you go to lunch and move people around. And then other times they will, depending on how the hours are going, they'll definitely be, they're expected to be the podium nurse. They're expected to review the trauma flow sheets, the cardiac arrest flow sheets, and really act as the partner to the attending physician.
Yep. And the question was about ratios, and the ratios really vary depending on patient acuity, because that could flex to 1-to-1 in a case of a post-arrest patient, or it could be 2-to-1 on most critically ill. It might be 4-to-1 on patients who really shouldn't be in an ED ICU. So I don't think there's a designated ratio. It just moves to whatever is necessary for that patient.
Yeah, and I think the Northeast, we don't have ratios, especially in New York. And I set a number that I think is the stretched ratio. That's what I call it, the stretched model, which is what I think your max should be. And it's exactly what you said. So if I have a post-arrest patient, then obviously the lead nurse will assume that nurse's responsibilities for her other patients or his other patients. If you have a post-thrombolytic patient, obviously in the first hour, a lot of work, a lot of tasks need to be done, a lot of monitoring. That's what we would consider the time frame that the lead nurse is going to monitor your other patients. But ideally, I really prefer a 1-to-3 ratio. Emergency medicine, we always say, right, we take more patients than everywhere else in the hospital. And we also do a different service than every other patient in the hospital. It's just, that's what it is. So I wouldn't say that I have strict ratios. How I staff the unit is probably a better answer. And I staff it based on my bell curved volume.
Yeah.
So I do an analysis of the volume for the month. And every month actually is different here on Eastern Long Island. And it's based on traveling, right? And snowbirds and this, that, and every other thing. I do it based on the month. And that's also how I approve vacations, actually, right? So I'll let more people take off in February than I would in July. And it's a bell curved process. So by 11 o'clock, my goal is to have 6 to 7. By 3 o'clock, it's 7 to 8. And then there's always an extra staff member. And that staff member has an assignment outside of the EDICU, and I would pull them in and when they're needed. Right. So if we got multiple trauma patients or multiple strokes, couple codes, and that for some ungodly reason, right, everybody comes in the same 30-minute window, I can pull that person, put them in there and get to 9. Right. And when we calm it down, I take that person out and give them back their assignment. Right. So it's a total dynamic process based on the acuity and complaints of the patients there.
Love it. And the other thing is, once critically ill patients are admitted after some period of time, we get floaters from upstairs to actually take care of those patients. So when you hear like 29 beds, you're like, that's still crazy, even with 8 nurses. Most of the admitted patients are being cared for by upstairs ICU nurses. All right. If you have more questions about that after that discussion, please let us know and we'll go even further into detail. All right. This one's going to be controversial, Candace.
Great. I love these.
A few people wrote, Drew was one of them, about adenosine. How is it best administered for supraventricular tachycardia? And I have very strong opinions on this, as you know. So
did anybody ask about
each of these?
Pads?
We'll get there. It's on the list, but let's save it for last. First up is dose. They want to know the dose.
Oh, we give 12, right?
Right. So you guys also are giving 12 milligrams up front?
Yeah, nobody gives 6 anymore.
Yeah, so that I think is a sea change for a lot of people. I also have just only give 12, and a lot of people are still giving 6. I think that is brutal to the patient because you only want them to go through this once. And to put them through it twice, oh, now we're going to go to the 12. It's just not nice. This is not fun for them. To the point where some people are like, we should just give diltiazem. I would rather just get the job over with the adenosine, but I give it one shot and it's going to work. So it's 12. So that's great to hear that we're on the same page on that.
Yeah, because the patient says, you made me feel like shit.
Yep.
And I don't want to do that
the second time. Yeah.
No.
And
we give 12, yeah.
And I have a paper in there showing increased efficacy from the 12, as you'd expect, and there's no increased side effects, so there's no reason not to go 12. This is very much like a cardio version. So I see some people, they're like, we start at 150, and then 200, and then 360. I'm like, what is wrong with you? Just give them the 360 biphasic up front. It doesn't cause heart damage. Just make it one shot and done. All right.
I wonder if the American Heart Association will change that. They're supposed to come up with an update this year, right? I think we're expecting it in October. And I wonder if they even suggest the 12, only the 12. Because remember, we used to give multiple doses. They cut one off. And so it'd be interesting to see if they got on board.
My prediction, and people could track me on this, is it's going to still stay 6 and 12. It's my guess.
You think?
Yeah. Just the way they play. But we'll see.
Smeed.
Hey, this future Weingart here. Just some additional adenosine information to pop into your brain. If you're giving it through a central line, you probably should reduce the dose. I don't know. I usually give 12 up front. I'd probably reduce it to 6 in a central line. If it was in the femoral, if it's right in the heart with an IJ, maybe try 3 first. If the patient is taking disopyramide or dipyranamol, that's Agrinox, or carbamazepine, you probably should reduce the dose as well. You might even want to go down to 3 in those drugs and then see what happens, and then maybe increase to 6 if necessary, because the patients can get pretty prolonged bradycardia. And then you actually need larger doses if the patient's on theophylline, but really, who's on theophylline anymore? Large blood levels of caffeine. I don't think that's just they had a cup of coffee before they got there. Or theobromine. I don't even remember the last time I've heard theobromine. All right, let's get back to the show. All right, this is where the controversy begins.
Oh, I love it.
How are you guys administering it now so that it goes in rapidly?
So we do the large syringe, right? So I draw the 12 milligrams, which is, I believe, 2 cc's, if I'm not mistaken.
4 cc's.
For 6, right. 2 cc's for 6, so 4 cc's for 12.
Yep.
And then I draw 16 cc's of saline in a 20 cc syringe, and I push that as one bullet. Because I find that if you're messing around with the stopcock, you're just losing like 10 seconds, which is a big deal with this medication. So we are the big syringe, 4 cc's of adenosine for the 12 and 16 cc's of normal saline in the 20 cc syringe. And we use 20 cc syringes, so they're at the bedside, because we talked earlier for our sedation, ketamine I like drawn in a 20 cc syringe. So you should have 1 or 2 in the back of your bedside cart or cabinets or whatever you got, because they are useful for more than just drawing the blood out of the A-line to redo a rainbow.
I'm going to go on a little side tirade here. I have worked in places where they stock just like 10 cc syringes. That's it. That is not the way to play. I am very adamant about this. You need 1 cc syringes that have the insulin needle. You need 1 cc syringes without the insulin needle. You need 5 cc syringes. I'm okay without the 3s. We could live without that.
Yeah,
you could have a 3 or a 5, whichever you like, dealer's choice. You need a 10, you need a 20, and then somewhere you need 60 ml syringes. They don't necessarily need to be in the main cabinets, but they need to be somewhere you could find them. And then you also need 60 ml slip lock syringes for dealing with NG tubes and stuff like that. So those are your syringe choices that you need. And if you don't have those, you should start stocking them, because you can't do the jobs we need to do without them. But the 20, the 10, and either a 3 and a 5 and a 1 should be in the bedside carts, available immediately, somewhere in the room that you don't have to go looking. So yes, absolutely, the 20 should definitely be there. I take credit. I switched your center over to the big syringe, and it was a big fight. Not with the nurses. They were fine with it, with the attendings. And I don't know why, but they were adamant about this stupid stopcock switching. And you could actually look at how often it fails, because someone turns the stopcock the wrong way, and they've gotten the adenosine, they haven't gotten the flush, it just sits in their arm and does. It's dumb. I have 2 separate studies on this in the show notes for this episode, talking about the safety and increased efficacy of the big syringe. The flush is built in. You don't have to think about anything. You don't have to put on any rigmarole, any apparatus. It is the easiest thing in the world. Just switch over, please, to the big syringe. Now, the only thing I do differently than you, Candace, because I've been burned on this, is I draw up the 16 cc's first and then the 4 cc's, because sometimes my friends forget to shake. And if they do it this way, it still works. In fact, it may even work better because the adenosine is being flushed by the enormous amount of saline behind it. But if you draw it up first and they didn't shake, there is a chance that what's left over in the syringe is a lot of your adenosine. Now, if you're fully flushing the syringe, it shouldn't matter anyway, but then it's not getting that flush behind it. Now, if there's any shaking just from walking around, it's probably enough to mix it relatively well. But what you really should do is just give it a good shake. But I like to draw up the adenosine last, and that just makes me feel better. But I think the way you just described would be absolutely fine as well. All right. Does the IV need to be big?
For adenosine? Is that what we're asking about?
Yep.
Oh, I think it needs to work.
Yeah, that's
like, I guess we could talk about, we talked about this before as well, like big. I don't believe in a 22 gauge IV for an adult. So it's defined big. Does it need to be 18 or 16? I don't think so.
Agreed.
And I don't believe in a 22 gauge.
Yeah.
I think if you're doing that, it's an unreliable line. I get that people think that the elderly need smaller gauged catheters. I am totally on board with the fact that they have sensitive skin, that they have that kind of geriatric approach, but that doesn't mean that their vascular got smaller and that they can't use a 20 gauge angio in their large vessels. Yes, if you're using this tiny petite thing in an elderly hand, that's one thing. But if I reach for an IV for somebody that's complicated, it's never a 22 gauge, right? It's a 20 gauge. And that's because I think that might be the only thing I can get. And you have proven me wrong in saying that you think that you want to use that. Don't.
Hey, folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
I want you to do this. And I was fine with what you chose, right? I think it would, you got mind over matter. You just got to say, if this can go, right? Kids, different approach, but adults, I don't use something small. So I think a standard IV, as long as it works well, I think that's the point. If you got to yank on it, pull on it, position it, it's not the best process. And that's definitely not going to handle the type of push that you need to do for this 20 cc syringe.
Yeah, I completely agree. You shouldn't be using less than a 20 gauge. And if you have a 20 gauge, it's going to be fine for the adenosine. Ideally, it will be up closer as possible to the AC. Hand will work. You might actually, even with the 12, need to give a bigger dose, and that can be scary. So to not scare people, it's nice to have something up in the AC, but we'll work with what we got as long as it's a free-flowing IV. All right. Do you raise the arm or not after you push it?
I do not.
Yeah, I don't either. I think if I
don't
had
know
it in
what
the
that
hand,
does.
if I had it in the hand, I might, but we usually get something in the AC. All right, now here's where the controversy really lies, Candace. And this created one of the most inexplicable fights I have ever had in my career. Do you put the patients on defib pads or not?
Oh, you had a fight about this.
Yeah, this was one of the most inexplicable fights in my career. We had a patient with supraventricular tachycardia. We told the nurse we were going to be giving adenosine. I walked into the room, and this nurse was excellent, super good nurse, and had great relationship with her, no problems. Walked in the room, everything's prepared. The syringe is drawn up, the IV is there, and the patient's on the defibrillator with pads. And I had nothing but joy in my heart because, like I said, I walked into the room with this excellent nurse with everything. Like, the nurses who you walk in and like everything you could possibly need is there. They've anticipated the entire procedure. And, this is that kind of nurse. She was top notch. And I said in a very offhand manner, again, with nothing but joy in my heart, on these patients, you don't really need to put them on the defib pads. You could just have the defib in the room. But I've never had a patient who we've needed to actually do anything with the defibrillator. We could just save some money. And I guess because my resident was there or the nurse felt chastised, even though that wasn't not my intent at all. And I didn't find this out at the moment. She didn't really say anything, but she held a grudge against me for like 3 years and really just a complete reversal. Our relationship went to crap, never talked to me about it. It was bad. And, the rule is you compliment in a group and you give feedback privately. But in my mind, it wasn't even like I said, the nurse had done this amazing job. And all the other nurses were putting these patients on defib pads. It wasn't like she was an outlier in that.
But I think that your point, so I do not put the pads on anymore. I think that you've changed that culture for me now. And I now move forward when I say you don't need the pads for this. I think people did it because they have this fear that the person's going to die.
Yeah, yeah.
And that's why people did it. And they needed to see that doesn't happen. And then people were on board. But I think you're right. It's some of the older attendings are like really hard to get past. And I think they just needed to know that I promise you this is not going to happen.
Yeah, absolutely.
So I don't anymore.
Now, these multi-purpose defib pads are not cheap. And there's a lot of hospitals, and I think Janus General is one of them, that just doesn't look at the unit costs of things. And they're very profligate with their items. But these are amongst the most expensive things you're going to use on a regular disposable basis. I like to say you should have a defib and a set of pads in the room. You don't want to go looking, but it's really as a talisman to ward off evil because you never need them. Adenosine is a ultra rapidly metabolized drug. I've in my entire career never had an incident where I needed to pace a patient. So putting them on the pads is a big waste of money. So just have them in the room if it makes you feel you're warding off evil, but you don't need to put them on. All right. Anything else you want to say about adenosine before we go on, Candace?
No, I think that's good.
All right. This one's just for you. What do you wish docs knew about ED resus nursing to make nurses' lives better and more fulfilling?
So this is the one question I thought about in the time that you gave me to prep here. And the answer I have is that we are better together than we are alone. And I think that's what I want you to remember. We bring two different skill sets to the table, right? I can't be you and you can't be me.
Can't come close.
I think that I spend more time with a smaller number of patients at the bedside because I have a smaller number of patients than you do because you're managing the room per se and I'm managing a portion of that. So when I have a icky feeling, it should be investigated. I think that's it. Is I have the approach that no opinion is disregarded and that makes us all work together better. And I think that's what I would want you to know is if I tell you something, it's because I felt like you needed to know. I don't tell you everything because I don't think you need to know that. And if I have a weird feeling about something, we should investigate it to make sure that I no longer have that feeling. Just if you said to me, Ken, I don't know, I feel like this person's gonna code. Can we move them to a critical care room from a high acuity room? And I'd be like, yeah, sure, no problem. That's because you had that feeling. I didn't just say, Scott, everything has wheels and we could just move the stuff. You had that feeling. And so I would do that for you, just as if I said to you, this guy looks like crap. I've done everything I can. They're still hypoxic. I've titrated up the oxygen. We've done the BiPAP. We got a gas. I'm just feeling like they're going to tire out now. It's not, you should investigate that.
I love it. So listen to your colleagues. That's good. All right. Next question is, and this is an ICU question. I don't think most EDs have this issue, though they might. So I think it might be pertinent. Should end-tidal CO2 be on the monitors or just the vents? I think this is one of those questions where the answer is already there. It's an ICU nurse, Hayden, who they have not put their end-tidals on the monitors. They can't see them. They're just on their Hamilton ventilators because it's built into the vent. You can chain those ventilators to the monitors, but their institution has not bothered to buy the cables so that they could see it on the big screen. What are your thoughts on that, Candace?
I grew up with end-tidal. We made it a basic necessity when we ordered new monitors, right? The investment has been worth it. And then I partnered with my ICU administrative nurse up in my medical ICU and she happened to be out when they were ordering her monitors. And I ordered all the stuff for her as well because it's the investment. To me, I put it on the monitor for two reasons. One, everybody's always looking at the monitor, right? And if the numbers look fine, they don't look at the vent. And then two, that it has that kind of alarm system. So it can give that variability and early awareness. And certainly alarm fatigue is where you hear all these bells and whistles and people just tune them out. It flashes, it's in a certain color, you know what it looks like. The profile is set for what you find to be needed. So for me, I like end-tidal on my bedside monitor. We don't use the Hamilton vent, so I don't have that feature. Even if I did, I would not take it off of the bedside monitor. I think it just offers that extra sense of security when it comes to alarming and that people look at the monitors. I don't find that people are looking at the ventilator unless there's a problem. If you're doing like your dope mnemonic, you'll look at the ventilator. But if your patient is doing fine, essentially the end-tidal on changes in the end-tidal on the monitor, I think, are seen better.
Yeah, I'd go a step further and say the NAP4 trial told us that every breath given in the hospital in a critically ill patient should be monitored with end-tidal CO2. That's a real avoidance of life-threatening complications. And the problem with having them on your ventilators is when you bag valve a patient, you're not going to have end-tidal. And that's probably one of the most critical times to have end-tidal. I would strongly urge EDs and ICUs to, first of all, you need waveform end-tidal for every patient that's going to be ventilated in any form. And it should be through your monitors, not through your ventilators. That way, when you're transporting a patient, you just take out the brick. They're going to continue their end-tidal monitoring. And that's really the way it should be done. And maybe you could use this as ammunition, Hayden, to tell your folks to at least chain the ventilators to the monitors. But I think in an ideal fashion, it wouldn't be through the ventilator. All right, Candace, what are your opinions about ketamine as a primary sedation strategy?
Like for an agitated patient or for an intubated?
I think they're referring to a post-intubation patient.
Oh.
And this is Asif who's asking.
Yeah, I guess it's not part of our everyday practice. I think I think there's a subset of patients actually that would do well with ketamine. It's just not my primary choice. I think it's hard to really get them to the RAS of what you're looking for because like the disassociation part, they're like really not, I think it's harder to control the people. I say the same thing even for the agitated patient, when we give ketamine, I am very different than giving ketamine IV. You never know what you're going to get. And I think that's what I don't like about ketamine is every person's a little different with it. I think there's a place for it, but I'm not sure that I would use that as my primary agent. It just would be very difficult to obtain what I'm looking for.
Yeah, I couldn't agree more. We keep it for patients who are incredibly hemodynamically unstable for that brief period until we could get them stabilized. You're crashing pulmonary embolism patient, fantastic to keep them spontaneously breathing. But really, we're just talking for a resus period. This should not be a long-term strategy at this stage of the game. And there's guidelines that I've linked to saying the same thing, that this should not be a long-term strategy. There are places for it short-term and then switch over to something else, like a dexmedetomidine if you have worries about hemodynamic instability or what have you. All right. This one, it's a whole rabbit hole here, Candace. And it was a rabbit hole I wasn't aware of. So you've switched to lactated ringers as your primary fluid in the EDICU. How does this interact with your ceftriaxone administration? Because there's been this thing constantly percolating that it's incompatible.
Yeah. So first, we use lactated ringers exclusively, whether you're in the moderate acuity, high acuity, or recess space. And we give a lot of ceftriaxone. And we've had not one problem. Other thing is, I think I might have mentioned this in the past, but pumps are challenging to find. So I'm of the method of if it's less than 100 cc's, you free hang it while you walk around to look for a pump for the Vanco or whatever else you're giving, linazolide, whatever, right? For me, I hang the ceftriaxone, and that takes about 15 to 30 minutes on your free hang. And then I hang the lactated ringers, or I have more than one IV and it doesn't matter to me. One goes on one side, one goes on the other. Or if I'm really giving volume at that time, I hang them together with in a Y site. And I've never, ever had a problem. And I've been doing that for a very long time. So I don't know where it's not clear that there's an incompatibility. I checked
Yeah.
multiple IV
I put a
compatibility
paper up
websites.
saying exactly what you said. Ceftriaxone's fine. Now, that same paper, this is why it's a rabbit hole, talked about things like ketamine being incompatible. And I'm like, what? I don't know. Maybe I know we have pharmacologists who listen to this. If you have real thoughts on this based on clinical experience or papers I've missed, weigh in and let us know, because we both combined have had decades and decades, including all of the people who are doing the same thing, switching over to lactated ringers, and no one's had a problem with ceftriaxone. I think that's a myth, but the other ones they've mentioned, things like ketamine, I've never seen it. Now, they're going to argue that this is all happening in the plasma. You wouldn't see it, that these calcifications probably don't have any clinical import of any vast amount, and therefore that's why you're not seeing. I don't know. Weigh in, someone. But I have a question more up your alley, Candace. A new trend that came out of the IV shortages, there were shortages of those 50 and 100 cc bags, where people studied the capability of just IV pushing things like cephalosporins, especially ceftriaxone, instead of giving it in a piggyback and just letting it drip in. Just give it as a push. And that seemed in multiple papers to be okay. I have 3 of them in the show notes. Have you started doing that? And if not, why not?
We haven't, but PEDS does it all the time, right? I think that we sometimes don't look at our current practice for our smaller volume people and apply it for our adult patients. Even blood products, right? They say, oh, you can't give a unit of cells through a 22. Really? Because
We do
a
it all the time.
2-year-old
Yep.
gets it. So why can't a 82-year-old?
Yep.
Right? And that's always what I say. So I think that we push to pediatric patients. Why can we not do that for adult patients? It's definitely an option. So if you're super concerned about the LR issues, you can definitely give it as an IV push, flush it with normal saline,
Yep.
and then give your LR bolus.
Exactly what I was going to
I
say.
think that's totally fine. For me, I order it in a piggyback, and that's
Ah,
how I order it.
got it.
And it's mixed. It's got a longer shelf life that way. It doesn't need to be compounded because it's just a roll down bag, hang it up on the pole. So it's that kind of difference. Some of our joint commission colleagues, which I know when they visit us, they just give us more work, but they don't like compounded medications, right? So if you can avoid those, that's what most institutions do. And it comes already pre-packaged in the bag, and you roll it down and hang it up and you're done. So even from a materials management spot, then I just need the med and the tubing, where if I bought vials, I would need a reconstitution solution. I'd need a flush. I need all this stuff. So where's the cost benefit in that? That you are correct. I don't look at any pennies that I spend, and I spend billions of them every year. Probably should not spend as much as I do, but whatever. I think
I could just take your bag and just squeeze it and get it into the patient in 2 minutes and then be done and then put the LRs. Okay, so that makes a total sense now. I understand where you're coming from. All right, Sarah writes. Now, Sarah is our most prolific commenter. We will do many cases in the future of things she has suggested. Sarah's awesome. I've tried to get her on the show. She is shy, but we might eventually convince her. But Sarah writes, a sick patient's brought in and people are struggling to find a pulse. This is one of those peri-arrest patients. Is there a better way than people like jamming their hands in the groin? Like, I have it, oh, I don't have it. Is there a better way to know immediately on a patient arrival if your patient's in arrest or not?
we use a lot of ultrasound, so I could tell you that's, what we're doing. My hands don't go in anyone's groin. And if you can't feel a pulse, then they don't have one. And I feel like if it's that labile or questionable or shitty, then you should just be doing CPR. There's no perfusion there. You're not going to hurt the person. It's very different if I said to you, can you please stop pounding on my chest? We've all seen people doing that, right? That's not what we're talking about here. So you can use point of care ultrasound if you're a shop that puts the ultrasound right on the chest, that we are one of those shops, the good or the bad associated with that. But I feel if you can't feel it, then the patient's not perfusing to what you consider to be adequate anyway. So why don't you just say it's not there?
Love it. What I do, and I think people are not using this enough, is something we talked about a few minutes ago. End tidal is the answer to this for me.
Oh, yeah.
Even before
sure.
ultrasound, because it's a whole thing. And then I have to trust the person doing the ultrasound versus I just put them on end tidal. If they're intubated, then you just put them on the adapter. But even if they're not, you could just slip on the nasal cannula with the end tidal on that. And if they have an end tidal greater than 20, they have a perfusing pulse. It basically pretty much tells you everything. If they don't, then you got to go searching for the ultrasound. It doesn't mean they don't have a pulse, but it means whatever pulse they have is not generating significant amount of perfusion or they're not breathing. And either of those needs to be remedied instantly. So that's what I do. They bring the patient in and I want that anyway if they have an endotracheal tube because I want immediate tube confirmation and we don't bother with someone looking with a laryngoscope. I think that's silly. So we'll just put them on the end tidal and the end tidal now will tell us the tube is in the right place and it will tell us if it's over than 20, they're probably okay for the next few minutes until we figure out what's going on. Versus if I see an end tidal that's 10 or nothing, then let's really go searching. Ultrasound, pulse, everything. Let's go full court press on this patient because there's an excellent chance they are in a ring.
Yeah, and our EMS colleagues are great, and most of them are already on end tidal, if not all. They're all intubated. It's very rare that we get somebody that's not. I guess maybe to play devil's advocate, what happens if the tube was in the belly and then the end tidal was 0 and the person had
like
a pulse?
I said, if it's over than 20,
right?
I could feel good. If it's not, then I have to now troubleshoot all sorts of reasons why this patient is not doing great. And that means we're going to have to look at the tube or just pull it. It means we're going to have to search for a POCUS pulse. We're going to have to search for an echo heart movement. We're going to have someone getting an art line and all sorts of things going on. But so that makes me frantic versus the 20 and greater. I just chill. I can listen to handover. I feel pretty good about that patient. All right. I got a question from Skippin' Red. This is from Instagram, so I'm sure that's not his real name or her. I guess it could be a she as well. Where to place the pads for cardioversion/defibrillation? And I'll start this one off, Candace, and you can tell me if you disagree. So if it's an atrial dysrhythmia, the literature would tell us that those should be anterolateral. So that's easy. You just place them both on front. For anything ventricular, then posterior anterior is markedly better. And that includes cardiac arrest. That's where you want the pads. We have multiple shows on that with Sheldon Chesky's. And even if it's a cardioversion for something like ventricular tachycardia, posterior anterior is better. That's my play. Candace, what about you?
Cardioversion, those patients are usually awake and can sit up. So I'm more of an anterior posterior for cardioversion. For cardiac arrest, it's variable. How about that? The diameter of a stretcher and the diameter of a human sometimes is the same. So it's hard to turn them over. So I think that we have put the multifunction pads anterior lateral. I actually turn the triangle upside down and I say that the tip of the triangle goes to the nip of the patient. So tip to the nip and then the other one goes on the lateral side. And people laughed at me, but you would be surprised. Everyone remembers me saying that. So we are an anterior lateral side for cardiac arrest. And that's because we found through actual reviews that we took way too long to turn the patient over. Way too long. And you were missing minutes there. So if you wind up needing them anterior, posterior, then you know what? We will start anterior lateral and then we will change them if needed. But for the most part, for cardiac arrest, we are anterior lateral, tip to the nip. That's what I teach people.
I would have been fine agreeing a year ago. I was on the same page, do whatever's easiest. Then I did have Sheldon Chesky's on the episode, and that's linked in the show notes. And he could not have been more clear that the data really points to a marked superiority for defibrillation success with posterior anterior. And at that point, we had to change practice at my place. And so I am strongly on the page of posterior anterior for cardiac arrest and for ventricular cardioversion. I don't roll patients, and this may be the reason I don't really have as much trouble with this. So what you want for me is I will be on the patient's left side with one hand on their shoulder, and then I need someone relatively strong on the patient's right side. And they should put one hand under the patient's right shoulder and one hand on their back just below their neck. And what we're going to do, and this is obviously at a rhythm check, we do the rhythm check and then we'll do this and do the rhythm check on EMS's stuff if they have just rolled in, because that's a real loss of time if you wait till they get onto your monitor. So do a rhythm check first, make sure they're not in a shockable rhythm. If they are in a shockable rhythm, shock the EMS with the EMS defib, and then you can do the transfer and do all this stuff. But on the count of 3, we just sit them up in bed. And now, all of a sudden, we don't have to roll them. Rolling's a huge pain in the ass, as you alluded to. We sit them up, and I will just slap on that posterior pad. And if they don't already have a mechanical device, then I will hold the backboard of a Lucas right under their armpits. And then as they lie down, they now have their posterior pad on. They have the backboard of the Lucas on. Someone can continue CPR. We can now slip a Lucas through their hands, and we could put the anterior pad on. And you really can get this down if you train on it to just a few seconds, and it's a lot easier than rolling them. So maybe Candace will get you to switch over the next few months.
Okay, and I could try. I'll need to pay attention to how long it takes. I don't know, maybe we're just not as strong.
Yeah, I don't know about that. There's some big burly women and men at your shop. I think if they are trying to roll, yes, that's a huge pain in the ass.
Yeah.
All right, 2 more questions. We're just on time here. And they dovetail with each other. So the first one is from Shanna, or maybe Shana. You'll tell me if I'm wrong. How do you tell the nurses they're not right for the gig? And she is a critical care educator in an ICU in this case. And she's got a few nurses that she just feels like, yeah, I could keep working on them. I could probably get them better. But she just thinks for their career longevity and happiness, they're just not right. They're not a good fit for the intensive care specialties. And she said COVID led to a lot of these nurses slipping through the cracks. They were very diligent about screening before they got there in the first place. But COVID, you took whatever you could get because it was such a dire nursing shortage. And now they're there. What advice do you have for her, Candace?
I think that you need to give real-time feedback. So maybe, and I know this either financially isn't loved upon by organizations, or maybe it's not something you can do, but somebody who's struggling, I personally get involved, right? So I have half a clinical role, half an administrative role, right? But when I am working clinically or someone is struggling, I make that my mission, because before I will tell them this isn't going to work, I need to see it happening for myself. It's really hard to give somebody negative feedback to begin with. And I think that you have to be involved. You have to give real-time feedback, and then you have to repeat that. And sometimes it's personality based, right? Maybe they're not meshing well with who's ever teaching them their preceptor on their regular training, or they're not meshing well with their colleagues and they can't ask for help, right? There could be that side of it. But before I go with this isn't working, I give my own independent assessment.
I love so much of what you said there. Let me pick some of it out and really emphasize it. First of all, you're already in a great position because you're one of the few administrators that does do clinical. And if you have an administrator that has lost their clinical chops or never really had them, and administration was a pathway of getting away from the bedside, I'm not sure those are the ideal people to be making these judgments. And if you're taking a judgment secondhand from someone else, and most of those secondhand judgments are very vague and very about click more than about skill. And they're like, yeah, she just can't hack it. Or he's just, he does, I don't know, I just don't like him. That's really nebulous to make an entire career choice for a person. So direct observation of an issue and then feeding it back to them in a way that isn't vague, saying when you were in the midst of that intubation and pushed the ketamine and then flushed and waited 3 minutes before you pushed the rock, that was a real problem. Let me know the thought process of that. That now you could start getting some insight into what's going on. So these direct observations with a trusted clinical expert, and hopefully that's you, but if not, then someone you really know understands your mindset on this stuff is huge. And if you have a person who you're giving help and tutelage, and they still aren't hacking it. I love the idea of giving them a choice and saying, look, we got two paths here. I have some feelings that at this stage, this is not working out as well as it could for you. Do you want me to help you find a different place? Is this working from your perspective? And then you could give them all the support. Or do you want to stay here and we just really have to together really work hard about really shifting a lot of things? And then it's really up to them, because if they're willing to put the work in, I've seen people turn around on the doc side, and I'm sure it's the same on the nurse side. But a lot of them, like when you give them the out, it's like, it doesn't mean you're a bad nurse. It just means this is not your fit. I'll get you a gig on another floor. Maybe we get you onto Onc. Maybe we get you somewhere else. That might be the out they've been looking for. So I love the idea of giving them the choice. Candace, Randy was asking, he's an NP in an ICU, and some of the nurses there, by the same token, are not performing. He doesn't want to rail them out of there. He wants to keep them, and he wants to know he's not in a nurse educator position. How does he, I guess Randy could be a she as well. You could tell me, Randy. How does he or she teach without the true named position? He wants to make these nurses better, but from a spot where he's not a nurse educator, she's not a nurse educator. How do you improve the quality when you're not really given the role?
So I think Randy brings a unique factor here, right? Because many people, like myself, chose to advance my degree, right? And many of your seasoned experts, best nurses are going to do that. They're going to become nurse practitioners and leave the RN role. And you need to make sure that you continue to have good bedside registered nurses, right? So Randy wants to keep that, right? He doesn't want every nurse to not be there. Otherwise, he's going to be standing there alone, or she's going to be standing there alone, right? Which is the last thing anybody wants. I think that's great. Let's start there, right? Because you want people, I'm a true believer in growth. I'm a true believer in helping everybody get to where they want to be and the person that they would like to be. But I think that it's a consistent approach. So if every month Randy should ask them and say, hey guys, I'm going to do a huddle, an educational huddle. We call it like buzzworthy, right? Buzz like a little bee that never goes away. So every month we send out Buzz News, which gives you a little bit of education, reminders, tips, issues that we found over the month that could be better, things like that. And you can use it to whatever you want. Post something up in the break room. Where we put things, the bathroom. Everybody reads something in the bathroom. You could read about using the 20cc syringe with adenosine in the bathroom. I think that if you ask them, what do we want to talk about this month, right? Is it that we're going to talk about cardiac arrest? You want to talk about sepsis, CRRT, whatever. And then you give them something small. It doesn't need to be a holiday meal worth of education. It could be a snack, but continuously looking at what you find as the deficit. And obviously, I ask people what they want to know, and I know the deficits. So I'll do one that they want and one deficit, one that they want and one deficit. So it's a little bit of integrated approach. And I think that if you just choose a topic for the month, you can raise their knowledge, because it's not forcing them to do the work, but it's providing the knowledge on a consistent basis. And you want to keep that team. Back to Shauna, what she had said in regards to how do I tell people? You don't want to push people out until you've gotten to a point where you're like, this is really not getting them to where they want. Because all the people at the high level eventually are going to become something else. Like at some point, I became an advanced practice nurse. Then I got my doctoral degree. Now I'm doing administrative work, right? It doesn't mean that I ever want to lead the clinical bedside. And you're right, Scott, most people in my role do not have any clinical ability. For me, I couldn't be a leader of 400 people, and they all think I couldn't do the job anymore. So I still do that all the time, right? Like I did a teaching scenario for a patient that needed to be paced on Monday, and I was in ambulance triage all day yesterday, right? Because one, I think the EMS personnel still need to see this face practicing so they don't just think when I ask them to do something, I'm like some dinosaur. But I also think that the new staff value the fact that they see me on the unit. Half the time they want to tell me to go away because nobody wants to work next to their boss. And when they do that, then I bring my lunch out and I stay longer because now I feel like you want me to leave for a reason. And I'm not quite sure what that reason is.
I love it. I will totally go with what you told Randy. I think it's a fantastic idea. If I had to play it, ideally, from what you've said, I would have him do the huddle and then type it up because there'll be people there that are jealous. They're not there. Don't just send it to the nurses. Send it to the NPs, send it to the nurses, send it to the attendings. On that email where you wrote it up, always give them the ability to opt out because they don't like, this stuff's being thrust on me. I have enough to deal with. Okay, great. Just send me an email back saying you don't want it. We'll take you off the list. But most people won't. Most people stay on, especially if they have the opportunity to get off now. They're like, oh, yeah, they're respecting my privacy. Okay, no problem. And all of a sudden, things start changing, like just small things start changing. Nurses, they actually care about making us better. I remember when I first got to Janus General, the nurses were always complaining, like, they don't care about us. No one's educating us. And then you got in there as nurse educator. I was working with you. We were doing a lot of nurse education. And I think it just changes the atmosphere. Little things start changing the morale and the culture of a place. And so your little huddles and sending out the emails might be enough to start the groundswell of people wanting to learn. So I think it's a fantastic idea.
Any education you give is not just for one discipline because everyone's starving to know what's happening. That's why I use my bathroom approach because we all use the same bathroom. But you'd be surprised. And I think the one unique thing is that while you guys think that Scott and I are BFFs here, we didn't start out this way. And I think that the partnership that we were committed to each other and committed to arguing with each other and doing it in a public space so people knew that we didn't always just agree. I think that's the change. So, Randy, people want to know that you care about them and they care about you. Your learning, your growth as a nurse practitioner, their growth as a registered nurse, your colleagues' growth as an attending or a resident. All of that is super important. I go to resident conference, I speak openly, and I go to resident education. So I think that's the point, Randy, is your training needs to be for everybody, not forced, readily available, and you'll find that your skill set of your nursing staff will increase from just something as small as that.
Love it. I think my only innovation for your brilliant bathroom idea was trying to tell you that it should be on both the front and the back of the bathroom because there are not just females. Yeah. And so that was a win, is we put them just above the tank and on the door so that
I
both
only had them on the door.
Yep. See? All right, Candace, that's the perfect note to say goodbye to folks for another month. And so we will see you soon.
Thanks, guys.